This intervention illustrates how health impact assessment can be used for humanitarian planning purposes. It is a collaboration between the ICRC and the Swiss Tropical Public Health Institute. The next presentation from Curdin is also connected to this work, and it will dive into the more technical details. I will focus instead on the programmatic aspect of it. So first, a little bit of background. ICRC has done a lot in the domain of urban infrastructure in Gaza over the years. Water production, disinfection, wastewater networks, operation and maintenance. Many projects always done in collaboration with the local utilities. The overall goal, keep services to an acceptable level to try to avoid major public health crises. However, having a sense if we were on a good track on these objectives has always proved difficult. Each dot that you see here is a facility belonging, in this case, only to the water sector. It is a project that we have done. 254 in 6 years, some big, some small. But you see that in some cases we have been working on the same facility 1, 2, 4, even 6 times. The realization is that this is more a firefighting modality rather than a deliberate plan. So in 2018, we attempt to have a better approach to infrastructure planning. We ran a multidimensional analysis to model the risk associated to infrastructure failure, how to optimize our internal planning processes to the specific constraints of the Gaza Strip. The results were put into action, and a new generation of project was considered. Projects that, from an infrastructural point of view, were more locally adapted. However, we were still missing a more direct connection with the specific local factors of essential services delivery, those factors that have a direct connection with the health of people. In particular, we knew that many risk factors were present, but because of the little epidemiological data available, we couldn't confirm the pathways of transmission and therefore the presence or not of impact in terms of health outcomes. So we basically started with a list of known unknowns. For example, salt intrusion and its potential connection to hypertension, or wastewater intrusion, and a list with truly unknowns, like antimicrobial resistant bacteria. We know that it's there, but what is the impact? Pesticide residuals in food, water. So in order to answer this question, we have established a partnership with the Swiss Tropical Public Health Institute. The idea being to use health impact assessment in a sort of a reverse order. Traditionally, health impact assessment seeks to identify the specific health impact of a given project. In this case, we have somehow reverted that order. We start from the impacts that we see, and we attempt to identify those interventions that might reduce them. And you see that in our intention, this approach is really at the other end of the spectrum compared to the firefighting mode I have described at the beginning. So from a planning, a programmatic perspective, there are, let's say, 4+1 milestones in this process. First, the +1, what is here marked with the 0. No regrets approach to evidence-based programming. I think it's pretty self-explanatory. It's about getting the consensus to work on this, not as a nice to have research activities, but quite the opposite. It's something that really inform how programming is done. Then, going more concretely, the first stage is the scoping, that has the objective to reduce the system, to make the initiative manageable. The initial review funneled those issues that were having both a high public health relevancy and at the same time that they were somehow within the ICRC capacity of interventions. These issues were further investigated to identify what critical information was missing. And that has generated a series of field investigation that aim to fill those critical information gaps. So multiple initiatives were put in place, and again, there will be a little bit more on this in the next presentation. But finally, in the fourth and last step, recommendations were produced. In the remaining part of this presentation, I will explain a bit better what this final step is about. But one general comment that I want to do now with the whole process in one slide is that this is, on one side, an evidence gathering process. You can see all the steps, let's say, on the left, and on the right, it's more a stakeholder engagement process to make sure that not only local authorities and service providers were heard since the early stages, but as well that local knowledge institutions, such as local universities, were involved in actually filling the gaps. And let me say that, at least in my personal view, this was by far the most impressive part of this work. So here is a snapshot of the third step. I'm only showing this. Curdin will provide more details, but I thought it was useful to have a sense of the transversality of the issue considered and the number of institutions involved in each of these issues. So finally, let me go through a little bit of the details of the final step, where everything a little bit come together. In this case, the first sub-step was to identify the local burden of disease. A comprehensive list of health outcomes, the disease affecting the population, has been computed and compared in terms of a common metrics. In this case, it was chosen to use years lived with disability. If you look at the major category of these outcomes, you see that now you can compare them. You can see who ranks higher. For example, a burden of more than 1 million years lived with disability is associated to mental health. The population affected in this case was the people older than 10 years old, which is approximately 1.5 million. So this metric is telling you that basically this issue is so transversal that basically everyone of that population has 1 year affected to it. So these values are indicative, certainly, but they provide an order of magnitude. They are enough to start getting a more nuanced picture of what is really important. Furthermore, the analysis has broken down the contribution of each specific modality of delivery of an essential services for each health outcome. For example, here you see the impact attributed to tap water on heart disease. Perhaps it's even more clear if you plot the contribution of essential services inside each bar, as you can see here. And even more if we consider the horizontal sum. At this point, you see how each modality of service delivery affect the overall burden. So finally, we can put all this information together. First, this table regroups the health outcome in 3 groups, from left to right in growing importance. The last 2 columns on the right account alone for 50% of the burden of disease. Then, specific suggestion of interventions, the rows on the left, generated in collaboration with the multiple stakeholders involved, have been assessed in terms of potential impact. And this finally represents the final result of this work. A starting point for specific planning aimed at tackling the chronic hidden issue of a specific context. Unfortunately, this process has been completely halted in October 23. For the first time, multiple institutions were collaborating on issues that by definition could not be handled by the perspective of a single institution, but that, on the other hand, were affecting the vast majority of the population. We believe that this process has a huge potential of aggregating local actors and humanitarian ones around key priorities, and that are not only evidence-based, but as well co-defined. Thank you.